Good evening, everyone. Welcome to the first webinar of 2025 from the Cervical Spine Research Society. I just want to thank my co-moderators, Mike McCarthy and Sanjeev Suratwala today for helping organize this, as well as to Maria Wendelberger from CSRS for helping us put this together. The topic of tonight's conversation is the management of cervical myeloradiculopathy with multi-level pathology. We've got a really great panel of speakers here today to discuss this topic. So I just want to put a plug in for the 2025 Cervical Spine Research Society meeting. It's going to be held in Washington, D.C. Be sure to submit abstracts. That deadline is going to be on April 15th. Also want to put in a plug for Clinical Spine Surgery. This is the official journal of the Cervical Spine Research Society. So please submit any papers regarding cervical spine research to this journal. And I think that you'll find that everything is, the topics are great in there. As well, please connect with CSRS. We're active on all the different social media channels. And then please be sure to check out the YouTube channel. This webinar will be posted on YouTube, and you can find some of our prior webinars on there, as well as some cadaveric techniques, as well as other presentations on there. And it's Brian Sue has done a great job putting together those this site. So please check that out. So for our agenda, we're going to start off with a case presentation by Dr. Mike McCarthy. He is a spine surgeon at Indiana Spine Group in Indianapolis, Indiana. And then we'll move on to our other speakers. So Dr. Tom Meraz from the Cleveland Clinic is going to discuss the role for anterior surgery. Dr. John Rhee from Emory University in Atlanta is going to discuss the role for posterior surgery. And then Dr. Hanny Malone from Scripps Clinic in San Diego is going to discuss the role of hybrid approaches. And then again, at the end, hopefully we'll have a good discussion regarding all these topics. All right, we'll start off with Dr. Mike McCarthy, who'll go into our case presentation.
All right, everybody. So I'm Mike McCarthy. I want to thank everyone who, not only just the attendees, but mainly my co-moderators, Venu and Sanjeev, and then obviously these excellent panelists or excellent lecturers that we're able to get tonight. So we were kind of thought of a case that could really spur in some discussion, and I think all of us have seen this in our clinic, and this is just something really difficult. Kind of sometimes we're scratching our head, I think, looking at the MRI. So we'll go ahead and kick it off. So this is a 67-year-old female with primarily complaints of neck pain, but also some right upper extremity pain, some associated paresthesias, and also over the past 6 months, she describes this progressive gait instability, but denies any falls, but states that it's getting pretty bad or tough to walk, and she's almost having to use a cane as a result. On exam, her exam's fairly significant for kind of right upper extremity decreased sensation, and primarily the C6 and C7 distribution. She does have some weakness on that right upper extremity, primarily in her triceps, and does have a unilateral Hoffman that you can see. Next slide. So we'll start off with her x-rays, and here you can see with the lateral and the AP, you can see some of the spondylitic changes, some of the disc degenerative changes that's associated with it, but no real evidence of any instability or spondylolisthesis present on here. Next slide. So here you can start to see the MRI. You can see the sagittal and the axial cut lines, and primarily what we kind of hope to see, you can hopefully kind of convey is just the amount of stenosis present, primarily at the C3-4 level. Next slide. Also at the C4-5 level, so you can see that there's a fairly significant cord compression. No evidence of any cord signal change whatsoever through this. And then can you go to the next one? You see at 5-6, you start to see some more foraminal narrowing and tightness on that right side more than the left. In the next slide, similar at 6-7 with some of that right-sided foraminal stenosis, especially compared to the left. So this is kind of the setup for the discussion moving forward. How do you think about this? How do you address it, both from radiculopathy and also myelopathy kind of standpoint? And let's kick it off with Dr. Meraz, thinking about how do we address this from an anterior approach.
Good evening, everyone. My name is Tom Meraz. I'm the chair of Enterprise Orthopedics and Rehabilitation and the director of spine research at the Cleveland Clinic. And I'm speaking today on the role of anterior surgery for the treatment of myeloradiculopathy. I do have some disclosures. I have royalties from Stryker. I am the deputy editor for Global Spine Journal, and I'm on the board of the Cervical Spine Research Society, none of which are pertinent to today's talk. This is an interesting case. This is a 67-year-old female with neck and right upper extremity pain and paresthesias, along with progressive gait instability without falls. The significant exam findings include decreased sensation to light touch in the C6 and C7 distributions in the right arm, as well as right triceps, mild right triceps weakness. and the patient has a positive Hoffman's on the right side. So when we look at the x-rays, looking at the lateral, she has maintenance of the cervical lordosis from C2 to 6, neutral between C6 and C7. And this is pretty characteristic in the 6th, 7th, and 8th decade of life, where we see patients start to actually have more cervical lordosis. But I'll get to the alignment in a few moments. But overall, this is the alignment would set her up for not only an anterior procedure, but also a couple of different posterior procedures that other speakers will discuss. On the AP on the right, these are non-contributory. At C3, C4, the patient has central stenosis, and we can say that because the patient has deformation of the spinal cord, posterior displacement, as well as effacement ventrally. At C4, 5, the patient has effacement, mild displacement posteriorly, and mild deformation of the spinal cord. And then finally at C5, 6, off on the right side, the patient has some mild to moderate foraminal stenosis, no central stenosis. Again, at C6, 7, the same sort of thing. Now, therefore, the clinical synopsis, this patient has mild to moderate myelopathy due to C3, C4 stenosis, possibly C4, 5. And I say mild to moderate. Number one, I don't have a JOA score to more objectively grade this, but the patient doesn't have any loss of hand dexterity on either side, nor is it noted that the patient has hyperreflexia in the upper or lower extremities, aside from the pathologic reflexes. The pathologic Hoffman sign on the right side, and the patient has not had any falls, thankfully. And on the right side, the patient has a C7, possibly also a C6 radiculopathy. And the patient also has neck pain. And I think that's very relevant, as we will see in a few moments. First and foremost, if we take a step back, we're faced with a patient with myelopathy, we ask ourselves, well, is there a difference between an anterior and posterior approach for the treatment of myelopathy? And there are a lot of studies as of 2025 that allow us to make a pretty clear determination. The first notable paper, in my opinion, is that done by Phalanx in 2013. This was an AO spine study. They looked at multiple sites, observational in nature, looking at 246 patients, giving us level 2 evidence, and this looking again anterior versus posterior approaches in patients undergoing anterior versus posterior surgery. And again, like Phalanx, he found that there are no differences between an anterior and posterior approach. Now, fast forward to most recently, where Dr. Gogolwala did a randomized controlled trial looking at anterior versus posterior approach, including single and multi-level ACDF versus laminoplasty and laminectomy infusion. And their objective was to compare in a randomized controlled trial ventral versus dorsal approaches with outcomes looking at 1 year. And they found with the SF36 of ventral versus dorsal at 1 year that there are no statistically significant differences between ventral fusion and dorsal laminoplasty and dorsal laminectomy and fusion. Likewise, the secondary outcomes, there's no difference between anterior and posterior approaches with modified GOA, work status, cervical SVA, health resource utilization, 1 and 2 year changes in the NDI, and finally EuroQoL 5D. But they did, however, note that complications were higher in the ventral. In fact, 23% higher complication rate in the ventral versus dorsal surgery. In terms of major complications, there was no statistically significant differences. However, minor complications, which include dysphagia, were higher in the ventral group, something that we would expect. Now, going back to our case, there are multiple considerations, and the first and foremost of which is alignment. This is a 67-year-old female. Overall, she's lordotic, as I discussed. However, the cervical SVA is probably close to 4 centimeters, and we know that we want this to be less than 4 centimeters before and hopefully after surgery. The T1 slope, again, unmeasurable in this case vignette, but it's on the higher end. And finally, I think if we were to check a scoliosis view, I bet that this patient's head is globally positive relative to her pelvis, and this is something that's very common in the 6th, 7th, and 8th decade of life. And I mentioned that global alignment because I don't think that posteriorly based procedures, obviously we're on a spectrum here, it's not absolute, but in general, patients who are globally imbalanced, despite what we see in the cervical spine, don't do as well with a posteriorly based approach. Neck pain also, this is part of this particular patient. Neck pain is a very big deal. I try to get a very good history on whether or not this patient has chronic neck pain predating the syndrome with which she's presenting. Is the patient mechanical, axial, or is it unilateral, possibly on the same side as the radiculopathy? And if the patient has cervical thoracic junction pain or trapezial pain, we oftentimes think of this as possibly being related to a radiculopathy, and this is something that we can easily work through with a selective nerve root block preoperatively. But in patients who have a tremendous amount of neck pain that I think is axial related to the degeneration of either the discs or the facets in the back of the spine, I try to tend away from a posteriorly based approach. I oftentimes lean toward laminoplasty, but neck pain is very controversial. And so there are many studies that demonstrate that patients who have neck pain, it is a risk factor for poorer pain scores postoperatively. And there are other studies that would demonstrate that neck pain, in fact, is not a risk factor for poorer pain scores postoperatively. But in my practice, if the patient has a significant amount of neck pain, I tend to stay away from a posteriorly based approach if I can. Now, there are different anterior only options, multi-level ACDF, a hybrid CDA and ACDF, and even a corpectomy and ACDF hybrid. But in this patient who has disease only at the disc space proper, I don't think, and she's not, as far as I know, at high risk for pseudoarthrosis, I would not consider an ACDF corpectomy hybrid in this patient. Now, because this patient has disease at C3-4, C4-5, and she probably, based upon the vignette and images, has radiculopathy either all at C7 or possibly also at C6. Obviously, there is some differences between innervation. Sometimes what we classically think of C6 can go over to C7 and vice versa. And so with the vignette, in this case, it's really hard to tell whether or not it is all C6 or all C7, but let's assume for a moment that the patient has symptoms, in this case, numbness and paresthesias emanating from C6 and C7 on the right. I think this patient would then benefit from a 4-level ACDF, something I don't usually do, but sometimes, I have in the past. So the pros, we get able to treat all levels. We certainly will be able to improve lordosis better than any other posteriorly based approach. Predictably, we get excellent outcomes, as we all know. However, there are cons. There is a higher non-union rate, particularly with a 4-level surgery, and we also have to contend with dysphagia and dysphonia, which this patient would be at a higher risk for. Meta-analysis of fusion rates. This is the Fraser and Hartle study in JNS 2007. Great study. They looked at multi-level and single-level surgery. I'm only including a cohort of the analysis, and you can clearly see comparing 2 to 3-level surgery, a 3-level ACDF with a plate has a lower fusion rate compared to 2-level. Now, this is all comers, all types of grafts, but we could pretty safely conclude that if we did a 4-level surgery, this patient is going to have a non-union rate, possibly 20% or higher. So to combat that, I think there are different options and different adjunctive therapies we can use and intraoperative techniques that we can employ, one of which is to fill the entire disc space with graft. I tend to decompress out to the pedicle bilaterally. It leaves a big space in excess of what a machine graft will fill, and so I will often take 2 grafts side by side and deliver them into the disc space proper. This is a photograph and an X-ray or a CT image from Dr. Dan Rube, but this is the same way in which I do it. In order to fill the entire disc space, you utilize all the real estate, and so I think, and I haven't seen any great studies comparing single grafts versus double grafts, but intuitively you would think that the patient is going to have a higher fusion rate simply because you're using all of the graft body interface and all the real estate for this particular fusion. Now, pulsed electromagnetic field, otherwise known as PEMF, as an adjunct does, I think, have merit. The first paper is Kevin Foley, and when I was a fellow with Kevin Foley, we did a randomized controlled trial looking at PEMF versus control, and we found that although there was no statistically significant differences in fusion rates between the control and the investigational arms, the patients, the technology was found to be safe. But there have been many publications using PEMF and the peer-reviewed medical literature since then. And there is likely some merit in increasing fusion rates. These are just two abstracts or papers rather that demonstrate that patients who are at high risk for pseudoarthrosis, in fact, have higher fusion rates when PEMF is used compared to controls. Now, dysphagia and dysphonia, overall, roughly, we quote 4% risk, but this is going to be higher in this patient with multi-level surgery, particularly with more rostral levels going up to C3-4. I think it's critical that you use proper exposure from the cranial to caudal to ensure that you have adequate excursion of the trachea and the esophagus to minimize traction on any of the nerves, whether it's the superior laryngeal nerve or the recurrent laryngeal nerve. And you also want to make sure that when you place your plate, that it is perfect carpentry, where there is no rocking of the plate left to the right, and certainly from caudal to cranial, that the plate is face to the cervical spine, and there's no proudness of the plate that could potentially give the patient dysphagia. But this is definitely a consideration in this patient in which I'm considering a 4-level surgery. Now, hybrid ACDF and CDA, certainly it's an option. In this case, I would tend to do the CDA for more caudal pathologies and an ACDF at the more cranial pathologies. I don't do a heck of a lot of the total disc arthroplasties, but you can consider this as a hybrid procedure where you would try to maintain levels of motion, at least a portion of the construct or the pathology being treated. So in conclusion, this is a common but it's a complicated problem where you have non-contiguous pathology. There are several factors, as I mentioned, that need to be considered when you're deciding, but I think it's really important as cervical spine surgeons that you have to be facile with all surgeries: laminoplasty, laminectomy, fusion, posterior foraminotomies, anterior surgery of a variety of different kinds, to understand and try to tailor the surgeries that you're going to be used for the specific patient with their specific pathology. So in this particular patient, my approach would be to carefully elicit a history regarding the neck pain. Again, is it chronic, mechanical? Does it predate the syndrome? Does it smell more like an axilla-related pain due to degeneration of the spine, or is it more radicular in nature? X-rays, I tend to measure the cervical SVA and T1 slope. I get flexion extension X-rays to rule out any instability, and I typically will get scoliosis films on all of these patients so I understand their global alignment. I want the head to be over the pelvis. And if everything checked out, I would lean, in this case, more toward a C3 to 5 laminoplasty with foraminotomies on the right side at C5-6 and C6-7. But as I mentioned, there are different options for this particular patient and ones like them. Thank you very much. I appreciate your time, and I look forward to the discussion.
Next speaker is going to be Dr. John Rhee, who is going to discuss the role for posterior surgery regarding this topic.
All right, well, I'd like to thank the CSRS for putting on this webinar and for inviting me to participate. In particular, thanks to Venu, Mike, and Sanjeev for the invitation. I'm certainly honored, and I look forward to the upcoming discussions that we have on this topic. Now, I have been tasked with discussing the role for posterior surgery, namely laminoplasty or laminectomy with fusion, in the management of cervical myeloradiculopathy patients with multi-level pathology. Now, clearly, posterior surgery plays a major role in the care of these patients, but the decision to go posteriorly is going to depend on a number of specific patient factors. And so what I want to do in this talk is to start by going over the indications that would favor a posterior approach, and then in those patients further discuss when laminoplasty versus laminectomy with fusion might be the better choice. But before I do that, let me put out this little caveat, and that is that all things being equal, I think an anterior approach is generally going to be the preferred option for most pathologies in the cervical spine. And the reason why is that there are a number of advantages to anterior surgery when dealing with cervical problems. First of all, it allows for a direct decompression of the majority of things that cause compression in the cervical spine, such as disc herniations, spondylotic osteophytes, annular bulges, etc. Now, the ligamentum flavum can certainly play a role in the cervical spine, but generally less so than it does in the lumbar spine. Another advantage to anterior surgery is that it's the best way to treat any associated foraminal stenosis. Not only do you remove the offending material causing foraminal stenosis when you go anteriorly, for example, again, disc herniations, osteophytes from the uncovertebral joint, etc., but you can also increase foraminal height in order to further decompress the root, and that's not something you typically do posteriorly. Another advantage is that it is the most facile way, in my opinion, to correct kyphosis. Like in this case of a patient with cervical myelopathy, where through a variety of releases and techniques, we're able to correct the patient from 38 degrees of kyphosis to 10 degrees of lordosis over the operative levels. Anterior surgery is also, in my opinion, the most reliable way to treat any associated spondylotic pain. Now, typically when we do surgery in the cervical spine, we're not doing surgery purely for axial neck pain. Usually the main goal is to achieve neurologic decompression of the cord and/or root. But neck pain is certainly an important symptom to try to relieve if possible in the context of treating these patients. And patients who have their neurology stabilized by surgery but don't get adequate pain relief may not be very happy, understandably so. And so we want to do what we can to try to address the totality of their symptoms to the extent that is possible. And I think anterior surgery is the best way of treating axial pain in that manner. And finally, anterior surgery is very well tolerated with minimal postoperative pain, certainly when compared to the posterior alternative options. So here's an example in which I think anterior surgery makes sense. A 55-year-old man with cervical myeloradiculopathy. He has right arm pain. If you look at the x-rays, there's overall mild amount of kyphosis. On the MRI, there is moderate to severe cord compression from C3 to C6. There is a congenital shape and a congenital narrowing of the canal with retrovertebral compression behind the body of C4 and foraminal stenosis down here at C5, C6. So you could imagine a scenario where posterior surgery could be done for this, but in my opinion, there are a number of factors that just favor going anteriorly here. And so by doing a C4 corpectomy, we can treat the retrovertebral and congenital stenosis. And then by doing the C5-6 ACDF, we can treat the foraminal stenosis and at the same time improve the patient's overall alignment from a mild amount of kyphosis to fairly normal lordosis. So those are going to be the advantages to anterior surgery. But having said that, there are clearly going to be situations where the posterior approach makes more sense as well. So what are those indications? Well, first of all, the greater the number of levels that are involved in the myelopathy, the more attractive posterior surgery becomes. Here's how I think about this conceptually. Now, again, this is purely conceptual. This is not based on any particular study, but more so on my experience. And I think those of you who have been around for a while will probably agree with this for the most part as well. But if you plot on a graph the incidence of postoperative issues, and by issues we'll discuss in a moment what that means, after anterior cervical surgery, the number of issues will tend to rise exponentially with the number of levels being done. So for example, if you do a 1 or a 2-level ACDF, the likelihood of a major issue post-op is very low. But as you get into 3, 4, 5 levels of anterior surgery, especially if you have to do a multi-level corpectomy, the likelihood of getting an issue like dysphagia, non-union, maybe even implant failure start to rise substantially. Now, if you do the same thought experiment with laminoplasty, the curve starts out a bit higher because there is a higher initial morbidity with a posterior exposure that is much greater than what a patient gets after a 1 or 2-level ACDF. But the difference is that with laminoplasty, the curve remains flatter because the incidence of issues and complications isn't as dependent on the number of levels that are being treated. So for example, whether you do a 2-level or a 4-level laminoplasty, the patient experience will be very similar, whereas I would venture to argue that for most patients after ACDF, a 2-level versus a 4-level makes a real big difference. And I think where those two curves intersect is somewhere around 3 levels. So if less than 3 levels is involved, the anterior approach is favored. And if you have more than 3 levels involved, then posterior surgery becomes more attractive. Now, if you have exactly 3 levels, it could go either way. The other reason is that the more levels that need decompression, the more facile the posterior approach becomes. So for example, if you have a patient like this with severe multi-level congenital stenosis involving the entire cervical spine essentially, you could do a multi-level corpectomy and fusion, but there's so many things that could go wrong with that approach. Whereas with a laminoplasty, it's going to be much quicker, easier to accomplish the decompression and reconstruction with much less hassle and headache. For similar reasons, posterior surgery is advantageous when the patient is more myelopathic rather than being radiculopathic. And that's because posterior surgery facilitates a very wide decompression of the cord. In my opinion, generally much wider than you can obtain with multi-level anterior discectomy. This is a patient of mine with a fairly severe 3-level cord compression that we treated with laminoplasty, and you can see that there is a very wide decompression over multiple levels that is achieved. And in my opinion, to get this level of decompression anteriorly, you would have to do a multi-level corpectomy. In contrast, whereas posterior surgery is great for decompressing the cord, it doesn't facilitate as effective a foraminal decompression. In most cases, we are doing an indirect root decompression when we go posteriorly, and in addition, there's no height restoration most of the time, which is why you generally get better outcomes with ACDF versus posterior foraminotomy for radiculopathy. Another indication favoring posterior surgery would be in those patients with significant multi-level congenital stenosis, multiple levels of retrovertebral disease, and OPLL. So here's a patient like that, a 55-year-old woman sent to me with severe progressive myelopathy. You can see on the x-ray that there is large amounts of OPLL behind the body of C2, C3, C4. At least that's what's visible on the MRI, on the x-ray. And then you can see similarly on the MRI, very severe multi-level cord compression. On the axial cuts, the OPLL extends from C1, C2 all the way down to T1, T2 with very severe cord compression throughout. And the CT scan shows that there is major OPLL in the cervical spine, and in the thoracic spine, she starts developing some ossified ligamentum flavum as well. So in this patient, for obvious reasons, we did a C2 to T3 laminectomy and fusion. I think doing this anteriorly, it certainly could be done, but again, there's very little reason to do that when there's a good posterior option instead. Now, in order to go posteriorly, you need to have preserved lordotic alignment. The reason being that a posterior approach is going to rely on cord drift back for decompression, which will reliably occur in the setting of lordosis, but will not occur if there is a significant amount of kyphosis. Now, it is true that even in kyphotic necks, you can get some decompressive effect away from the dorsal structures, like the ligamentum flavum and the lamina, by doing a posterior decompression, but because of the kyphosis, you don't get drift back away from any anterior compressive structures. And finally, it is true that even if the patient is not lordotic, as long as there is a flexible kyphosis, or one that's correctable through a posterior approach, then posterior surgery could be considered for those patients as well. There's an in-depth talk on this topic that's available on the CSRS video archive at csrs.org. And over time, all of those talks, as well as any additional ICL talks, debates, lectures, etc., given at CSRS have been migrated over to the CSRS YouTube channel. And so this is a talk that you can look up in either of those websites. But for our purposes today, let me summarize by saying that you can categorize cervical deformity according to its flexibility. And if it is flexible, meaning that you can passively correct the curve into a desirable alignment, then all posterior surgery is an option. As it was in this case of a 61-year-old woman with myeloradiculopathy, flexible kyphosis, and a dropped head type syndrome. You can see on the MRI that indeed the deformity is quite flexible when she lies supine on her back, and there is multi-level moderate cord compression. And because the curve is flexible and the neurology as well as the deformity can be treated posteriorly, we did a C2 to T4 decompression with fusion. Now, sometimes the deformity may not be flexible. It may actually be completely fused and ankylosed, but if a posterior osteotomy can achieve satisfactory realignment, then again, the posterior approach may be chosen. And this is a 68-year-old woman that was sent to me after multiple front-back surgeries done elsewhere. She had progressive myeloradiculopathy and difficulty holding her head up. On exam, she had a chin-on-chest type deformity with a very stiff, non-reducible kyphosis, but she had normal motor strength throughout. On the MRI, you can see there is residual cord compression at C3-4. There's also severe cord compression at T1, T2 with an associated degenerative spondylolisthesis and significant bilateral foraminal stenosis. Here are the axial cuts showing residual cord compression at C3-4. C6-7 has moderate compression, and T1, T2, again, the level with a slip is very severely compressed. On the CT scan, there's severe C1, C2 arthritis on the right side. There's residual OPLL, and that's what you were seeing at that C3-4 segment despite the anterior surgery that had been done. And there was a solid fusion from C3 to C6. So this wasn't a flexible deformity, but I felt that both the neurology and the alignment could be addressed through a posterior approach. And so we did a T1 pedicle subtraction osteotomy, not only to realign the spine, but to provide an indirect decompression of the spinal cord away from that residual OPLL. And the patient did very well after this with complete resolution of pain and improvement in her myelopathy as well. So those are the indications for posterior surgery. when would we then choose a laminoplasty after we have decided already on a posterior approach? Well, in my opinion, the ideal indications for laminoplasty are in those patients who have multi-level myelopathy with preserved lordotic alignment and minimal axial pain. If you have that type of patient, a laminoplasty, in my experience, is generally the treatment of choice. And laminoplasty has a number of advantages. It's a motion-sparing operation. You don't fuse anything, so the patient can completely avoid any associated morbidity related to fusion, like implant complications, non-unions, excessive loss of range of motion, etc. In addition, there's much less likelihood of developing a significant kyphosis post-op after laminoplasty versus if you do a laminectomy alone. Now, I will admit that some loss of lordosis does occur even after laminoplasty, especially in those with pre-existing non-lordotic alignment, if they have a high cervical SVA, or if you fail to preserve or adequately reconstruct the extensor musculature. We can talk about that more in depth during the discussion section, but for now, suffice it to say that the likelihood of these issues will be significantly less with laminoplasty versus laminectomy alone. In addition, laminoplasty has neurologic and clinical outcomes that are similar to that of anterior surgery, and this has been borne out in the literature historically dating back to the early 1990s and more recently in the randomized controlled trial published by Zoe Gogwala. And finally, laminoplasty has a very low long-term reoperation rate. Being a non-fusion operation, you don't have to deal with reoperations from either non-unions, mechanical failures, or accelerated adjacent segment disease like you can see after multi-level anterior cervical fusion. Well, what's the evidence for the low reoperation rate? Well, we recently published in 2024 an average 8-point-year follow-up post-op laminoplasty and found that, as expected, the MJOA scores improved significantly by about 3 points from pre-op to post-op. NDI scores improved significantly as well by about 17 points. But importantly, we found that reoperations were very rare over this 8-year follow-up period. There was a 1.9% rate of recurrent surgery for radiculopathy due to progressive spondylosis, and these patients underwent a 1-level ACDF. Similarly, there was a 1.3% rate of reoperation for myelopathy due to disc herniations, again requiring a 1-level ACDF. The average time to reoperation was 3.2 years. There were no reoperations for adjacent segment disease, and none of these patients had any kind of plate failures or premature laminoplasty closures. So this is a very durable operation with excellent outcomes and a very low reoperation rate. But what about the issue of neck pain? This is a criticism of laminoplasty as well, that it may somehow create or worsen neck pain postoperatively. So we looked at that question as well in 2017 and concluded that laminoplasty doesn't lead to worsening axial pain in the properly selected patient. We included 134 myelopathic patients without significant axial pain based on their VAS neck pain scores being less than 4, and found that in the laminectomy with fusion group, the pain scores went from 3.3 pre-op to 1.3 post-op, improved by 2 points overall, and this was statistically significant. In the laminoplasty group, they started out with less pain, 1.8 pre-op, and went to 1.6 post-op. This difference wasn't statistically or clinically, for that matter, significant, but the point is that the pain in these patients did not worsen. It actually got slightly better. And so if you have a patient with minimal axial pain pre-op, they're likely to have minimal pain post-op as long as you properly perform laminoplasty. So here's a perfect indication of a patient who does well from laminoplasty, a 75-year-old woman with painless myelopathy. You can see that she has significant cervical degeneration, as you would expect in somebody in her age group, but she has lordotic alignment. There is multi-level, at least moderate to severe cord compression from C3 to C7. Again, clinically, she has no pain, just myelopathic symptoms. And so I did a C3 laminectomy, which is what I typically do in these patients, versus a C3 laminoplasty. We can get into the nuances of that in the discussion section. But combined with a C4 to C6 laminoplasty, and the patient postoperatively had no pain either, and her myelopathy improved significantly. Now, here's a patient that at first glance you might not think would be a great candidate for laminoplasty. There's severe multi-level disc degeneration in the upper to mid cervical spine. There's an upper cervical kyphosis, and he presents with myelopathy and unilateral neck and arm pain. On the MRI scan, you can see that he is autofused through the C3-4 disc space. There's moderate to severe cord compression at C4-5 with signal change. There's some dorsal compression coming in primarily from the C5 lamina, and there's mild to moderate cord flattening at C5-6 with symptomatic foraminal stenosis. So Although at first glance this might not be the best patient for laminoplasty, he had lordosis where he needed it, namely at the levels of cord compression from C4 to C6. So I did a C5 to C6 laminoplasty with foraminotomies, and postoperatively his neck pain and arm pain went away, the myelopathic symptoms went away, and you can see that his overall cervical alignment remained stable as well. So finally, what about indications for laminectomy with fusion rather than laminoplasty? Well, in my opinion, it's really limited to the patient who is otherwise a candidate for posterior surgery, but has either a correctable multi-level kyphosis, like in this patient, where we did a C2 to T2 decompression with fusion, or extensive OPLL to the point where multi-level anterior surgery just doesn't make sense. For me, a multi-level cervical laminectomy and fusion is really an operation of necessity. I only do it if there are really no other good options. Not because the patients don't do well, don't get me wrong. Neurologically, these people do well because you have decompressed and stabilized them. But in my experience, they just don't thrive as well as the anterior surgery or laminoplasty patients. And that's because I think a multi-level posterior cervical fusion leads to a stiff neck that most patients just don't enjoy living with. And so if there are any alternative or creative ways of doing anything else to patients like this, perhaps combining anterior surgery with laminoplasty, I prefer that in most cases rather than doing a straight up C2 to T2 fusion. Again, unless it is absolutely necessary. And so with that, I thank you for your attention, and I very much look forward to our discussions.
Next up, we'll have Dr. Hani Malone from Scripps Institute San Diego talk about hybrid approaches.
I'm Hani Malone from the Scripps Clinic and San Diego Spine Foundation, and I'm going to discuss hybrid approaches to cervical myeloradiculopathy involving multiple levels. Thanks to the Cervical Spine Research Society for hosting this event and for having me. I'll start with a clinical case. The patient's a 52-year-old gentleman with a history of a 5-6 ACDF following a trauma. He's developed adjacent segment disease above and below. He does have some chronic myelopathy, likely related to the original injury, and he presents with progressive pain and weakness, primarily affecting a left C7 and C5 distribution. Looking at the MR, you can see that the patient has left C5 and C7 foraminal stenosis that would explain his radiculopathy, but he also has some degenerative changes at 3-4 with moderate stenosis that are currently asymptomatic. It was great hearing from Tom and John, and we know that these types of problems can be treated from an anterior approach or a posterior approach, but that those are not always ideal. And in certain instances, a more hybrid technique may be what's best. So what are some hybrid or unconventional treatment strategies for cervical spondylitic myelopathy? Well, there are anterior hybrids, which involve an ACDF and a cervical disc replacement. That's been well studied and where we'll spend most of our time today. There are also some posterior hybrid strategies. Obviously, a lot of patients that have deformity or pseudo-risk, they may need a circumferential fusion, but that's not really a hybrid, and so we're not going to discuss that today. Instead, we'll talk about ACDF with posterior lami alone, if that can be achieved in an MIS way, also ACDF with laminoplasty, and briefly ACDF with facet fusion. So starting with anterior approaches. Obviously, ACDF has been the gold standard for many years and is a great treatment strategy. Currently, cervical arthroplasty has gained a lot of popularity, and for good reason. It's been a really successful treatment that has benefited many of our patients. But in the future, may there be a role for combining these two treatment strategies to tailor treatments for specific levels and specific patients. Certainly a great deal of academic interest when it comes to cervical arthroplasty and hybrid structures, and you can see that PubMed submissions have increased nearly exponentially over the past 10 to 15 years. The arthroplasty data has been fairly compelling. This is a meta-analysis by my colleague and mentor, Dr. Trinellis, of 11 random controlled trials. At 2 years, he saw no difference in adjacent level operation, but there were significant decreases in adjacent segment pathology both at 5 and 7 years, suggesting that cervical arthroplasty may have superior longevity. In this separate meta-analysis of 11 random controlled trials, cervical arthroplasty achieved better NDI scores, patient satisfaction, patients were more likely to recommend it. They had better arm and pain scores and less symptomatic adjacent segment disease with less secondary surgery. Of note, despite this picture, I am not an advocate of 4-level arthroplasty. There's no shortage of evidence that suggests cervical arthroplasty outperforms ACDF in both single and multi-level disease. So the question is, why not just do it on everybody? Well, some levels are really just not appropriate for cervical arthroplasty, and there are certain pockets of the country where I think the envelope is being pushed. But there are certain levels and certain patients where arthroplasty is really just not the appropriate treatment option. The benefit of hybrid surgery is that patients with multi-level pathology often have different levels of degeneration throughout their spine, and hybrid approaches allow you to individually tailor treatment to each level. They also have the potential to mitigate the risk of adjacent segment degeneration on long constructs. So back to our original case, a 52-year-old gentleman with a history of a C5-6 ACDF following a trauma. He has adjacent segment disease both above and below with progressive pain and weakness. MRI shows left C5 and C7 foraminal stenosis, which corresponds to the distribution of his pain and weakness, but he also has fairly moderate stenosis at C3-4, which currently appears to be asymptomatic. The patient was interested in arthroplasty, but he did have pretty significant axial neck pain. We got a SPECT scan to see if there was any increased uptake in his adjacent segment facet joints, which you can see there was not. Importantly, this isn't a sure thing, but sometimes it can be helpful in trying to better identify causes for axial neck pain. And since there was no obvious facet uptake, we decided that it would be reasonable to attempt an arthroplasty. So in this hybrid approach, you can see that an anterior cervical discectomy infusion was done at C6-7 and an arthroplasty was placed at C4-5, both to treat the patient's left C7 and C5 radiculopathy respectively. At C6-7, the amount of disc space collapse precluded an arthroplasty in my opinion. There was a fair amount of spondylosis at C4-5, but with some carpentry, we were able to get the arthroplasty to fit relatively well. The patient did do very well following surgery, and you can see that the images look relatively decent, but there is, if you look closely, a small fracture that was incurred in the C5 vertebra while trying to remove the bone, which was sort of encased over the arthroplasty plate, the ACDF plate. So we'll have to follow him closely. Another patient that had multi-level disease with C5, C6, and C7 radiculopathy and also had neck pain. He got a SPECT scan, not to focus too much on this technology, which is still not fully proven, but subsequently got an interarticular injection at 6-7 on the left, which did provide quite a bit of relief of his axial neck pain. And so this treatment strategy in this instance involved ACDF at 6-7, where he had both radiculopathy and facetogenic axial neck pain, with arthroplasty above at C4-5 and C5-6. In this third example, there was a gentleman with just classic C5-6, C6-7 degenerative changes and pretty bad radiculopathy. And he being a young man, we decided to attempt a C5-7 arthroplasty, but you can see that intraoperatively he had really large shoulders and visualization of that C6-7 disc space was very difficult. And this is with columnation, pulling on the arms, etc. And since we couldn't adequately visualize the disc space, we were prepared to do an ACDF at that level where high resolution visualization is not quite as critical, and he did very well from this treatment as well. What does the data say? There's more and more data becoming available. Despite that picture on the right, I don't necessarily advocate for putting an arthroplasty in between two fusions, but in this retrospective review, there was pretty good outcomes, at least at 2 years, with no reoperations for persistent or recurrent symptoms and no failures. Well, what about the biomechanics of hybrid constructs? In this study, it showed that there was a benefit in the sense that you'd have the decreased range of motion at the ACDF where you'd expect, but you had preservation of motion at the arthroplasty site, very similar to an intact spine. Interestingly, they did not find any real significant difference in the biomechanics, whether the arthroplasty was placed caudal or cranial to the fusion segment, which is something that might be worth discussing after we're done with our talks. This is a separate biomechanical study, a finite element analysis that looked at adjacent segment, comparing two-level ACDF to a hybrid construct. And you can see that the adjacent segment had quite a bit of increased intradiscal pressure in the ACDF model, where the intradiscal pressure only increased by less than 10% in those hybrid constructs. There is some population level data as well, looking at the NISQIP database. And in this instance, for early outcomes, 30 days, there was no inferiority for hybrid constructs compared to ACDF and cervical arthroplasty, at least demonstrating no short-term inferiority. In this retrospective review looking at two-level hybrid constructs compared to two-level ACDF, you can see that there was no difference in complications and that the hybrid patients had a lower rate of reoperation and shorter length of surgery, and their 30-day outcomes were equivocal. And more data is becoming available that suggests that hybrid constructs are at least as good as ACDF and arthroplasty, and in many instances offer some benefits. Importantly, hybrid constructs do appear to at least decrease the risk of adjacent segment degeneration compared to multi-level ACDF, as shown in this study of 100 patients that had follow-up out to 2 years. They had greater range of motion. Importantly, their alignment was not significantly negatively affected by the arthroplasty, and as hoped, they had decreased adjacent segment degeneration. Finally, a meta-analysis of 3 different studies comparing hybrids to cervical arthroplasty, showing that the hybrids actually returned to work sooner and that there were no significant differences in functional outcomes or range of motion between the 2 groups. Back to our initial discussion about where to place the arthroplasty in the hybrid construct, all things being equal. Generally speaking, I like to place the ACDF below and the arthroplasty above, but there have been a number of kinematic studies that suggest there really is no difference as to whether or not the arthroplasty in the hybrid goes cranial or caudal to the fusion device. Constructs compared to other motion-sparing techniques. We looked at about 100 patients who had laminoplasty compared to hybrid anterior approaches. And as you can see, there's no difference in the pain and function scores. The alignment improved more, as you'd expect from the anterior surgery cohort. And importantly, the range of motion was not dissimilar between the 2 groups. So I think it's important to pay attention to the patient, the radiographic findings, the operative factors. You can individualize treatment per level with the goal of maintaining motion where appropriate. And you just have to consider the overall goals of surgery, both your goals and the patient's goals, alignment, motion, adequate decompression, and so forth. But I think that hybrid surgery from an anterior approach is definitely a viable treatment option and can be very successful in the right patient. I want to briefly touch on a hybrid approach that involves anterior cervical discectomy with laminoplasty. In full disclosure, this is not something I do with any frequency, but there is a study from the International Journal of Spine Surgery in which they combined cervical arthroplasty with laminoplasty. The thought being that the anterior approach was better for foraminal decompression in patients with severe radiculopathy, and that the laminoplasty could be used to treat multi-level cervical stenosis. There are other studies that show laminoplasty for the treatment of failed ACDF. Of course, if somebody has a pseudoarthrosis or a failed ACDF, they may still continue to have neck pain, in which case I would advocate for a posterior cervical fusion. But there are some studies that suggest the 2 can be combined in a positive way. Of ACDF with laminoplasty, I think that the obvious question is, why would you do laminoplasty versus just a laminectomy if you've already got a fusion in the front? Well, if you do posterior cervical surgery, oftentimes patients will have quite a bit of muscle atrophy, and by placing the laminoplasty, you expand the canal, but you also allow for better healing because the posterior elements of the spine are in place, and the muscle tends to heal to the posterior spinal elements with a better rigor than if you have a big laminectomy defect. Like many of you, I've had patients with posterior cervical approaches, and the recovery from that procedure, particularly in the elderly, is not an easy one. And so I wanted to at least entertain a few other treatment options. This is the case of a fairly frail elderly lady who had had a non-instrumented 2-level ACDF and developed adjacent segment disease both above and below. Below there was a spondylolisthesis as well as above, but there was also pretty severe radiculopathy below. And above, you can see that in addition to severe stenosis from the slip and some disc degeneration, there's a really robust ligamentum flavum. So in this case, I used an ACDF to treat the spondylolisthesis and the foraminal stenosis from an anterior approach, but I don't think that adequately addressed that large flavum, which likely continued to create stenosis. And so I just dropped a small 16 millimeter minimally invasive tube to release the ligament. And this is something that I've done a number of times. It avoids having to make a big posterior incision, and I think it's an effective way to treat the problem without creating too much morbidity in a somewhat hybrid approach. Finally, there's more data now available for the use of these posterior facet fusion devices. in multi-level ACDF. Admittedly, not something that I've used with great frequency. This is a young patient who presented to me who'd had a 3-level fusion with ACDF and posterior facet fusion. As you can see on the CT from the right, a fairly robust fusion, but developed adjacent segment degeneration at the C7 T1 level with C8 radiculopathy. I wasn't too keen on just placing like a standalone ACDF device at the cervical thoracic junction, but she was also very much against having a standard posterior approach for obvious reasons. I simply extended her ACDF 1 level, but also augmented it with a posterior fusion device to try to confer some additional stability without having to do a full posterior exposure, and it appeared to work well. So if all else fails, remember that you always have hybrid strategies available, as this surgeon employed using just about every different surgical technique you can imagine. Thanks to our hosts, Mike and Vanu. I look forward to seeing you both in Washington next year. And I know Phil isn't a part of this, but he's just an easy target. All right. Thanks, everybody. Bye-bye.
All right. Well, thank you. Thank you to all the speakers. Those are all really excellent talks, and really enjoyed hearing them. We have several questions in the Q&A, so I'm going to jump in and just kind of get us started. And this is a question for first for Dr. Mraz, and then be curious to hear everyone else chime in as well. You mentioned in your talk that you typically put a CDA more caudal if you're going to be considering a hybrid approach. And several of the questions in the chat had discussions about when you'd consider a hybrid type procedure, when you might do it in association with either a single or a multi-level fusion. The topic today was, multi-level disease and pathologies. So when would you consider doing a hybrid procedure, and you just kind of go into a little bit of your rationale for using it on the more distal end rather than more proximally?
Yeah, well, typically, what I've learned through the various courses at CSRS and through the literature, I mean, the higher end, C3-4, particularly C3-4 is where I'm really talking about. CDAs that typically don't work as well biomechanically. Now, that is not a hard and fast rule. I mean, clearly, many people do them at higher levels, but from a hybrid approach, I think what would make sense is if you have a patient who's got a burned out disc that is not a candidate for CDA, that perhaps, for example, it's C6-7 or C5-6, and then they have a relatively preserved disc at the higher level at C4-5, then you consider doing an ACDF at 2 levels and then a CDA at the other level. There isn't any hard and fast rule for this, but I think when you have preservation of the disc height, minimal spondylosis, but still you have a symptomatic level, whether it's a radiculopathy or a myelopathy, in conjunction with other adjacent levels that are more spondylotic yet and symptomatic, then you would you can consider a hybrid procedure in any position. I don't think there's a hard and fast rule where you have to do the CDAs more distal or versus proximal. That's just my opinion, but it's open for discussion.
Hey, Tom,
go ahead.
Tom, since we kind of got you on this, you mentioned about getting long films or getting scoliosis, or even maybe some people in the audience have access to an EOS. It's kind of obvious when you see those pretty chin-on-chest deformities or pretty significant deformities, but is there any more subtle things that you're morphing away from your standard AP lateral cervical films and saying, well, maybe that subtle finding is leading me to getting scoliosis films to get a better sagittal?
Yeah, I've just been fooled. I mean, particularly in the older population, when you're talking in the 6th, 7th, and at the 8th decade of life, I mean, oftentimes these patients have preserved lordosis, or at least they're neutral. Yet when you have them stand up in your clinic, they are not looking neutral from a global perspective. And earlier on in my career, I never used to get scoliosis films. And we would base our approach traditionally, anterior versus posterior, on a variety of different things that were discussed today. Kyphotic, we go anterior and so on and so forth. But, I think that the patients who have a posteriorly based approach, particularly laminectomy and fusion, who are globally imbalanced, I don't, just like another speaker said, I don't think they do as well. There isn't a lot of hard and fast literature on this because I don't think there's been a lot of literature that has looked at global alignment in patients who are having either anterior or posterior surgery. Laminoplasty and global imbalance also I don't think does as well, at least in my practice. Now, I don't think they do terribly. But when you have a patient or a cohort of patients that seem, at least in my opinion, come back with higher pain scores in the neck, I mean, it makes me wonder. And so we are looking at this through research at the clinic, trying to figure out, well, either is there truth or is this my conjecture on patients who are globally imbalanced? And so from my perspective, when I'm looking at a patient and I'm considering, I oftentimes lean toward laminoplasty. I do think it has a lot of merit. But I also, when I'm doing laminoplasty, I do get scoliosis films for the past 5 years on all my patients. And if they are globally imbalanced, and I don't, I wish I can give you a number, but I look at this, cervical SVA, I look at the T1 slope, and I look at the pain scores before ahead of time, and I look at their global alignment, both clinically and radiographically, and I just have a gestalt of what works for me. And you think what we need to do is be more objective about this and look, ideally at a multi-centered prospective study so we can really start to answer these questions. And I don't know if any other faculty have noticed this or not, or if it's just my opinion based upon my 20 years at the clinic. But I do think there is a difference in patients who are globally imbalanced.
Yeah, I think you make a really good point. Actually, I also get scoliosis X-rays on all these patients, and I think the key is that a lot of these older patients, they will start to develop, whether it's from compression fractures or degeneration in the lumbar spine, this global imbalance, and they actually become really dependent on their cervical lordosis. And the cervical lordosis is actually a compensatory mechanism for their lumbar or thoracic malalignment. And so, as Dr. Rhee, I think, had mentioned that patients that have, you're considering a laminoplasty, they do lose some of that extension capability. Just even if you're careful with the muscles and careful with the dissection, they're going to lose a little bit of that extensor power, which can potentially, in the setting of a pre-existing, global imbalance, can worsen and start to have potentially an increased risk for loss of cervical alignment after surgery.
Yeah, I would say that
Yeah.
to follow up on that, I think the global alignment is definitely important, but honestly, I don't necessarily get full-length X-rays on all of these kind of patients. I think it's important to consider because number one, you don't want to make the alignment worse. But on the other hand, if somebody comes in with clearly a cervical problem and cervical myelopathy, especially if they're older, I mean, you could talk yourself into doing a huge operation to try to correct their overall alignment, which they may or may not necessarily need. So I think those are all really excellent points and important to consider, but sometimes you also kind of want to focus on the problem at hand and not necessarily create other issues just based on the radiology.
Yeah, absolutely. We don't want to turn all these patients into C2 to pelvis fusions,
Right.
for sure. So, Dr. Rhee, I had another question for you. In terms of, you showed one of the cases that you showed, you did a laminoplasty on a patient with a large anterior cervical disc herniation at C3-4. And, this is, I think, something where I've struggled, and I've, sometimes done hybrid approaches where I'll do an anterior procedure and then couple that with a laminoplasty, one of the hybrid options that Dr. Malone talked about. How do you decide, when posterior surgery is enough when you have let's say, a large soft disc herniation anteriorly?
Yeah, I mean, I think generally I would probably only do that if it was part of a multi-level problem. If it was a one or a two-level problem, I'd probably just tackle that from the front. But for me, the K line's important. Looking at the K line and determining whether or not a posterior decompression would be sufficient. And if the K line is positive, meaning that you're likely to get away with a posterior decompression, then that's the choice I'll take. But you obviously have to factor into account the overall alignment, the fact that you don't want to lose lordosis and cause the K line that was positive to subsequently become negative. Those are also things you have to consider as well. But if they're nicely lordotic, the K line's positive, and you just kind of look at the MRI and the X-ray in your mind's eye and imagine what it would look like after a decompression. And if you think the cord will be decompressed appropriately, that's sort of how I decide.
We have a really good question by Ilya Salim where he is asking on the Q&A, is there ever a role for if there's 1 to 2 levels of pathology that's primarily posterior kind of ligamentous base? is there a role for any type of anterior surgery in those situations? John, do you want to chime in on that?
Sure. So, I think there were some cases where we saw a lot of ligament and flavum build up posteriorly. And I do get nervous about that because if you go anteriorly, there's two important points though. If you go anteriorly and you're able to get height restoration, then I think a lot of that ligament and flavum infolding will actually improve. But if for whatever reason you don't get height and you just get pure lordosis, that's when the infolding of the flavum can actually get worse. So you want to make sure that you mobilize the segment well by doing a very wide discectomy, releasing as much of the tissue as possible, and don't necessarily think about putting a highly lordotic implant in there. Get something that will get you height and some lordosis, and then I think you can do an anterior operation for primarily posterior pathology, but I do worry about that.
I think that's a great point, John. I have a similar take. And the thing that always worries me, I mean, the natural history of myelopathy oftentimes is that folks won't get worse, but they won't get immediately better. And if you've got a big flavum and you do an anterior operation and you don't see immediate results, there can be a lot of hand-wringing as to whether or not you've actually adequately decompressed their spine. And so I'll do an anterior approach if there's a reason to, like a spondy or a radiculopathy or some reason that, would warrant doing it. And then you can always drop a little tube or what have you. But if it's just largely posterior pathology, my preference is laminoplasty or lamina infusion, depending on their alignment.
There's been a lot of, I think, fervor to adopt, motion preserving technologies and cervical disc replacements. Dr. Malone mentioned that in certain parts of the country, it's almost, taken over ACDF in terms of the amount of surgery that's being done. I'm curious what you all think in the setting of a congenitally stenotic canal. We often see patients who have, multi-level stenosis, partially from congenital stenosis and partially from spondylotic disease. When do you think it's appropriate to perform a cervical disc replacement in the setting of a congenitally stenotic canal? Dr. Miraz, you want to take that one?
Sure. I think from a treatment perspective, any patient who has preservation of the disc with minimal spondylotic changes, in my opinion, even if they're congenitally stenotic, as long as you do a good decompression, you could also do a disc arthroplasty. Put another way, any case that you're going to do an ACDF, as long as there's minimal spondylotic changes, you can also do disc replacement.
Yeah, I think for me, if it's primarily a soft disc herniation is when I would consider something like that. And you'd also have to imagine that, there's not a whole lot of posterior flavum buildup and that it's primarily from an anterior soft disc herniation. That's when I might consider arthroplasty in that scenario.
And I don't have a whole lot to add. I think if the pathology is ventral and otherwise amenable to arthroplasty, I think it's very reasonable, but not if it's, congenital or posteriorly based.
I'll ask a question to the panelists here. When you have this, or we've had this conversation over anterior, posterior pathologies, when you're having a conversation with a patient about this, do you ever get into the conversation about, we're going to try and do one approach and maybe we'll do it as a stage. We can do a follow-up MRI to see if the posterior pathology resolved or how much residual stenosis you have. Is that part of your normal workflow when you interact with patients prior to surgery?
Yeah, that's a good question, and it goes back to a previous question. In patients who have considering a laminoplasty or even a laminectomy infusion for a multi-level disease, but they have a single level that is very large from a ventral compression standpoint, I do have that conversation with them. And my protocol is to do the posteriorly based procedure in those patients, but then while they're still in the hospital, I will go ahead and get an MRI while they're still in house to see whether or not the cord is still compressed. Now, if the patient has absolutely zero improvement, then we can consider the same hospitalization going in from the front if the patient's there for a number of days. Oftentimes they'll feel some sort of benefit. It's not going to be the actual, the ultimate benefit that they get that we follow them for a period of time, but we can see whether or not they usually get some degree of benefit. But if they don't get any benefit, I always have that conversation that we may have to go in from the front at a later time. But those are that's the only situation where I have that conversation. Typically we try to make these surgeries as durable as possible and as definitive as possible. And usually I think we're successful. Obviously, we're all spine surgeons. We see a number of revision cases if we're in practice long enough where patients come back. I think the other thing that's really helpful in managing that is getting JOA scores and all the other measures ahead of time before surgery so that we have an objective comparison by which we can measure the postoperative improvement or lack thereof. And I think that helps over time, helps us as surgeons inform our conversations moving forward, because we know when we're in practice long enough, we do enough surgery and we're objective enough about how we perform as surgeons, we're able to start to have not only the expertise of clinical practice, but we also that's informed by measuring things before and after our own surgeries. But that's the way in which I practice.
A great point, Tom.
All right, great. Well, I think we're going to end it there. We're a little bit over time. Thanks to everyone who tuned in today. I really want to thank all of the speakers for their excellent talks and the discussion at the end, as well as the moderators for helping with setting this up. I also want to thank Maria Wendelberger again for her assistance in getting this organized. Thank you, everyone. Be sure to tune in later this year for our next series of webinars, and hope you all have a great evening. Thank you.